we as physicians in primary care don't seem to be able to incorporate effectively enough of the information about the mental status of patients. Do you think that needs to change?
There are some aspects of other disciplines in medicine that I have to consider as a psychiatrist. We're trained, for example, that before you can make a psychiatric diagnosis, you should rule out medical. Before I diagnose clinical depression, I should ensure that you don't have hypothyroidism, which can present looking exactly the same as clinical depression. I think that analogy carries over to psychiatry. We would be wise in our society to have an all-hands-on-deck approach to decrease the risk and increase prevention of these kind of violent acts. We shouldn't wait until there's an initial consideration of a problem before we send someone to a psychiatrist for a formal assessment. Any more than a psychiatrist, if somebody walks in my office limping and they said maybe they have a broken leg, I got to get them to a doctor to manage that. We all should think that how a person thinks and engages, that's important, and we all should recognize that we have an opportunity to have a blanket of an assessment strategy that is far-reaching, much more likely, I think, to have a high sensitivity, so to speak, and to capture more persons who may be at some risk.